Thank you for joining us this afternoon. I'm Ryan Holeywell, and I am the Executive Director of Mission Communications at Blood Cancer United. I'll mention this webinar is being recorded, so everyone who's registered will receive an email with a link to that recording. For 75 years, Blood Cancer United has stood with blood cancer patients and their loved ones. We're funding life-saving research, providing free information and support services, and advocating alongside patients for quality, affordable healthcare. And of course, that's what brings us here today. We're looking forward to sharing more with you about a new tool we've produced with our friends and colleagues at the Georgetown University McCourt School of Public Policy's Center on Health Insurance Reforms. We call it What to Ask About a Hospital, and it is a first of its kind guide to understanding how financing structures vary across U.S. hospitals. We believe this resource will be a powerful tool that empowers advocates, researchers, reporters, and policymakers to ask the right questions and obtain the information they need to advance policies that make healthcare more affordable for Americans. So here is what we have planned for today. First, you'll get an overview of this new tool and get some ideas on how to put it to use from Connell of CHIR. And after that, we'll move to a panel discussion with state and federal experts who can explore how a more nuanced understanding of hospital finances can support greater accountability and smarter policymaking. They'll also offer some real world examples of how you might be able to leverage this resource and put it to use in your own work. And then lastly, after the discussion, we'll have plenty of time for Q&A. So I definitely encourage you to submit your questions for our speakers at any time using the Q&A box at the bottom of your screen, and we will respond to as many questions as we have time to. So now let me go ahead and introduce our speakers. As I said, first you will hear from Kenna Watts. Kenna is a research fellow at Georgetown University's Center on Health Insurance Reforms, where her research focuses on policies that promote healthcare affordability and accessibility. In particular, Kenna researches provider and payer pricing, ERISA preemption and fiduciary duties, out-of-network billing, and the No Surprises Act, and state and federal oversight of hospital market behaviors. She is an author of the What to Ask About a Hospital report, and worked on the project right from its inception. After her presentation, we'll have our panel. Our first of our three panelists is Caitlin Westerson. She's Senior Director of State Policy and Advocacy at US of CARE, where she builds state partnerships to advance healthcare reforms that expand coverage and improve affordability. She brings deep experience leading high-impact state policy initiatives, including helping to create the Colorado Option Public Health Insurance Program and Colorado's Prescription Drug Affordability Board during her time advising the post-Primavera administration. We'll hear from Maureen Hensley-Quinn. She is a Senior Program Director at the National Academy for State Health Policy, where she leads the Coverage, Cost, and Value team focused on how states finance, deliver, and improve coverage through public and publicly subsidized health programs. She directs NASHP's children's coverage work, supporting CHIP directors nationwide and helping states streamline eligibility, enrollment, and renewal across health coverage programs. And our third panelist is my colleague, Brian Connell. He's the Vice President of Federal Government Affairs at Blood Cancer United, where he leads a team of federal lobbyists covering a diverse portfolio of issues, including access to care, clinical trials, and cancer research, cost of care, pediatrics, among other topics. Brian has 15 years of experience across government, industry, and the nonprofit sectors, and he's got a track record of securing impactful policy changes for patients. Thanks for joining us today. I should mention we want to thank Christine Monahan, our colleague from CHIR, who had hoped to participate in this. You'll still see her commenting in the Q&A, but she is ill today, that time of the year. So just wanted to thank Christine and appreciate everything she did to help with the report and to prepare for this event. So now I would like to welcome Kenna to share her overview of the guide. Thank you, Kenna.
Yeah. Hi, everyone, and thanks for having me. As Ryan mentioned, I'm Kenna Watts, a research fellow at the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. And before I dive into the presentation, I just want to echo Ryan's comments that Christine is the lead author of this guide, and I've really seen this guide be a labor of love for her and our whole team. And over the course of the project, it's just been a real pleasure to partner with the Blood Cancer United team, as well as our expert consultant, Ariel Winter, on this project. And if you're not familiar with CHIR, if you are familiar with CHIR, you may have known that we've been studying private health insurance for well over 15 years, but in recent years, we've really expanded that focus to examine the broader healthcare system, recognizing that we need to bring a more holistic lens to ensure that everyone can get the coverage and care that they need at an affordable price. Next slide, please. And really, at the heart of this work is evidence-based policymaking. And that's what this guide is really about. This guide is not an advocacy piece, but instead is meant to serve as an educational resource that policymakers, advocates, media, and others can turn to as they develop, evaluate, write about, or vote on different policies. And this information is particularly crucial now. Hospitals, no doubt, play a hugely important and necessary role in our healthcare system. We need them. And they are facing a tumultuous landscape exacerbated by deep cuts and changes to the Medicaid program and marketplaces. But research has also made clear that commercial hospital prices have played a leading role in driving up healthcare spending. And patients and consumers, employers, and state governments, like some hospitals, are really struggling financially and need relief. And so policymakers face significant pressure to find this balance between ensuring that we maintain access to high quality hospital care, but also ensuring that we are paying a reasonable price that is affordable now and over the long haul for everyone. Next slide, please. And it is therefore critical that everyone participating in the policymaking process understands the regulations, payment programs, and reporting requirements that apply to hospitals and the source of information that are or are not currently available about them. And this is really no easy task. There are multiple definitions of hospital under federal law, and any individual hospital may be categorized in a number of ways. The legal and regulatory framework applicable to any individual hospital depends on the amalgamation of categories it falls under. And so crafting thoughtful policy depends on understanding these nuances, whether you want to use them and work within them, for example, by exempting an existing subtype of hospital from a certain reform, or you want to pursue reforms that might upend things more significantly. For example, maybe changing what hospital qualifies for what exemption or adjustment, or making more or fewer funds available through one pathway or another. Next slide, please. So with Blood Cancer United, we have created this guide as a starting point to understand the organizational and financial differences across hospitals in the United States. And in the guide, we focused on federal law and programs, and particularly Medicare, given the program's comprehensiveness and influence over other payment systems. With respect to Medicaid, we do discuss the federal financial support for and the federal laws governing the Medicaid program, as well as the federal limits on state flexibility. But to avoid the guide becoming too unwieldy, it does not document the multitude of ways that state laws and programs add further complexity to this landscape. And we hope and intend for this guide to be of use to a broad range of audiences, state and federal policymakers and their staff, the advocates weighing in on hospital reforms or affordability policies, and the reporters covering these issues, among others. Next slide, please. So theoretically, someone could sit down and read the whole 50-page guide straight through, but keep in mind those 50 pages do not count the appendix. And while I do think that the guide does offer significant value to those who take the time to do that, we certainly do not expect everyone to do that. And for that reason, we have organized the guide and the material in a way that is accessible in bite-sized pieces. So the guide has 4 main substantive components, which I'll walk you through in a moment. But generally speaking, as you go deeper into the guide, you'll get more detailed information about the different ways hospitals are paid and categorized. And at the end, we'll point you towards resources to learn more about specific individual hospitals. But for the most part, every 1 to 2 pages of this guide can stand on its own. And in this way, if you want to have a focused conversation on one topic, for example, nonprofit hospitals or Medicare DISH, you can simply pull out those 1 or 2 pages on that topic without having to dig through everything else in the guide. And to make readers' lives easier, we've prepared each of these 1 to 2 page fact sheets as individually downloadable files that you can access on our website. And while the full guide is filled with internal links to different pages to enable you to quickly hop around, the separately downloadable files all include external links to the other topic-specific fact sheets. So you can get the information you're looking for as easily as possible, and you aren't just sent back to the 50+ page guide. And you can also separately download the bigger sections that interest you. So say you're very interested in rural hospitals. We have a PDF ready that has all of our rural hospital fact sheets consolidated together. Next slide, please. So beyond those technicalities about different downloads and different ways to access the guide, I think it's important to get into the different key components of the guide itself. And it starts with what we call the questions to ask about a hospital. And this component effectively serves as an outline for the rest of the guide. It includes 6 key questions that you could ask of or about any hospital, with some follow-up probes to better understand how the hospital might be classified. And within each question, we offer a brief 1 to 2 sentences that explain why the question is important or relevant. And as with the other parts, this 1-2-pager could be pulled out to stand alone for someone who doesn't want to go too deep into the material, but is really interested in understanding the different ways to categorize hospitals at a high level. But at the same time, it's full of links to additional information that we share later in the guide for those who want to learn more and dig a little deeper. Next slide, please. The second core component of the guide is the hospital payment and accounting explainer. And this is really meant to demystify complex hospital payment systems. It offers 101 level information on hospital patient revenue, as well as how each major payer type, Medicare, Medicaid, commercial plans, pays hospitals. And it also provides an overview of the public sources of hospital cost and financial accounting information, including the Medicare cost reports, audited financial statements, and IRS Form 990s, and describes the key hospital financial measures. And this section really intends to serve as an enhanced glossary of key terms and concepts. So readers can refer back to this explainer when they're in other parts of the guide and realize they need a refresh on some of the basics. Next slide, please. And the third component of the guide is when we get into the real meat. Through several short color-coded fact sheets, this component provides readers with information on important hospital classifications and explains how those groupings influence hospital operations and finances. So these 6 collections cover, first, how a hospital's organizational form, that is, whether it's a nonprofit, for-profit, government-owned hospital, as well as it's a part of a profiter system or not. Second, the type of care a hospital provides, whether it's general acute care hospital or it specializes in certain conditions or populations. Third, a hospital's geographic location. So for example, whether it's a rural or otherwise isolated hospital, and whether it qualifies for one of Medicare's rural hospital designations. Fourth, the extent to which a hospital serves low-income patients, which when we're thinking about the federal payment programs, generally relates to whether a hospital qualifies for Medicare or Medicaid DSH payments or the 340B program. Fifth, whether or not a hospital is a teaching hospital. And finally, whether a hospital participates in alternative payment models. Next slide, please. So each of the 6 collections in this component of the guide start with a brief overview, and this overview explains how a certain hospital classification influences operations and finances, and essentially expands on the questions to ask about a hospital 2-pager. The content of each overview varies depending on the specific classification. But if you look at the example we've included here on the slide, you can see an overview of how a hospital's location matters. And in this overview, we offer a mix of definitions, some substantive analysis of federal rules, and some data we've calculated from Medicare cost reports. Next slide, please. So following the overviews, there will be 1 or more individual fact sheets for the specific forms a hospital may take or the programs in which they participate within that broader overall category. So, for example, within the section on the types of care a hospital can provide, we have individual fact sheets on children's hospitals, as you'll see here on this slide, as well as fact sheets on general acute care hospitals, PPS-exempt cancer hospitals, and rehabilitation, psychiatric, and long-term acute care hospitals. And in these fact sheets, we tend to describe the eligibility rules or how a hospital qualifies for a particular categorization, and then what that means as far as their treatment under Medicare and the 340B program. For example, if a hospital qualifies for any enhanced payments or special privileges. And depending on the fact sheet, we also include some descriptive information largely derived from the Medicare cost reports or other research that gives you a bit more insight into who these hospitals are, why they're treated differently, and where they tend to be located. And so as you can see on the example here on the slide, and for nearly all of our hospital fact sheets, the top right corner includes an approximate aggregate operating margin for the group, which is effectively the weighted average operating margin. And these estimates come from our analysis of revenue and expense data reported on the hospital's 2023 Medicare cost reports. And just to be very clear, this is not an indicator of overall financial health of these hospitals. That would be a lot more complicated to ascertain. And this is also not representative of any single hospital. It's looking at that group of hospitals as a whole and giving us a sense of their overall level of profitability at the facility level. Next slide, please. But if you're interested in even more data, most of our collections conclude with a by the numbers section, which lets you see how hospitals within a category compare across a variety of metrics. And we've primarily focused on facility characteristics rather than cost or financial measures here, just because of limitations in the cost report data we're using. And what we've really sought to do here is give readers an understanding of how these different categories of hospitals overlay and interact with each other, and allow you to look at them from different angles. So, for example, on this slide, you can see that only 11% of for-profit hospitals are located in geographically rural areas, while 34% of nonprofits and 57% of government hospitals are in rural areas. And so this tells us something about the behavior or choices of hospitals based on their ownership model. But if you were to look at the by the numbers sheet for the location section of the guide, you can see that data flipped around. So there you would see that among rural hospitals, 10% are for-profit, 55% are nonprofit, and 35% are governmental. And so that's telling us something about what rural hospitals tend to look like from an ownership perspective. Next slide, please. So after diving deep into each of the 6 key facts collections, the final core component of the guide identifies resources for readers who want to then apply this information and learn more about an individual hospital. So this section includes external links to a range of sources about ownership, payment classifications, and individual hospital finances and operations. And to be very clear, you are not going to find the name of any individual hospital in our guide. That is not the purpose. But these resources allow you to do that individual research on your own. And then if you need to, refer back to the guide to get more context about the hospital you've identified. Maybe now you know it's a PPS exempt cancer hospital, a low volume hospital, or a teaching hospital. And while we didn't include it in the slides, the guide concludes with 12+ pages on our data methodology and a list of sources we consulted in preparing the guide. So this too would direct you to where you can learn more in case you're still itching for more information after 50+ pages. Next slide, please. Now, our next speakers will be discussing how to use the guide, but before they do that, we just wanted to offer a couple ideas. The original use of the guide was to help someone who wants to know more about an individual hospital. So say you're having a meeting with a critical access hospital representative, or you were looking at a bill that wants to exempt critical access hospitals from a facility fee ban, for example. But you're a little fuzzy on what a critical access hospital actually is. So by turning to the guide, you should get a good picture of the federal rules and regulations that govern critical access hospitals, how they're paid by Medicare, and also get a sense of how many there are nationally, what parts of the country they tend to be located in, and what other sorts of characteristics are common among them. And maybe while you're doing that, you'll see that nearly all critical access hospitals participate in the 340B program. And so you'll jump over to the 340B 1 to 2 pager to better understand how the program works in case it comes up in your meeting. You can also use the guide to begin to understand some of the ways different hospitals face different circumstances. So the image on the slide came from a poster we made for the 32BJ conference this past October, where we did a high-level comparison of a couple of hospitals in New York. The first hospital, I'm sure you've all heard of, New York Presbyterian. But the second, you likely haven't if you're not local, and that's Lewis County General Hospital. And while you can see that these hospitals have a few key things in common, and maybe even more in common than you initially might have thought, we can also see there are some pretty important differences between these hospitals. And so policymakers may want to consider whether any of these differences should factor into policies they're crafting. And to add another layer to this, Christine, Ariel, and I recently published a Health Affairs Forefront article, which we'll shortly share in the chat, that draws heavily from the guide and illuminates important policy debates and developments that turn on or implicate these distinctions. As one example, rural hospitals are obviously top of mind for everyone these days, and the guide offers readers a lot to chew on in terms of how to define and identify rural hospitals, as well as the variation across the different types of rural hospitals. I found in my own work, this guide has really helped me understand the complexity of hospitals much more and bring a much more sophisticated lens to our thinking about how we shape hospital policy and reforms. And with that, I hope you all check out the guide and please don't hesitate to reach out to us if you have any questions. Thank you so much.
Thank you. Thank you for that overview, Connell. That was wonderful. Well, now I would like to welcome our panelists to the virtual stage. Brian Connell from Blood Cancer United, Caitlin Westerson from US of Care, and Maureen Hensley-Quinn from NASHP. So let's start off with you, Brian. And Kenna did a wonderful job at the end of her conversation, starting to give us some ideas about how we might be able to apply this. From a federal advocacy perspective, tell us a little bit about how you think this can inform policy making about prices and costs and financial viability, especially in the context of some of the decisions and debates that are happening right now.
Yeah, it's a great question, and it's how this whole project came about. We at Blood Cancer United, having a lot of discussions with policymakers, and we know that hospitals play a really critical, really essential role in ensuring that people can access healthcare. Patients need access to hospitals. Hospitals provide really, really important care. Policymakers, though, are tasked, both the elected officials and their staffs, with making critical decisions on a whole host of hospital-related policies. At the federal level, you have Medicare payment, Medicaid payment, you have 340B program, graduate medical education, medical debt reforms, financial assistance policies, you have provider consolidation that folks know is happening, both vertical and horizontal. They are really making decisions almost every day on hospital-related policies. And they know, I think anyone who follows healthcare or even just gets healthcare knows that intuitively, hospitals are not a monolith. You see a children's hospital in a downtown, metro center, and you understand that's different from a county hospital in a rural area. It's kind of standalone, which is also different from a big system where the name just rings true because you see its facilities all around the state. Like folks know that those are different entities, but I think what we'd heard from staff in particular at the federal level, we had staff coming to us and saying, we're trying to write bills, we're trying to understand, where to draw lines, where to say, as we think of where to make reductions in payment for hospitals and where to invest more in hospitals. Like we know that some folks are really profitable. We know that some folks are underwater. How do we help solve that? And there was a real difficulty. Staff came to us and said, we don't know how to draw these lines. We don't know how these different categories overlap. There's, as Connell walked through, there's a whole host of different categories, and while some of them are actually separate, some of them are overlapping, and so it really is difficult for a policymaker to understand what first of all, what does this rural designation mean? Does it mean that this is in a rural area? Does it mean it's serving mostly rural patients? Like how help me understand was really what we had heard. And so that's why, we brought this to the fore. And I think that's why we've been met with glee, I would say, from policymakers, as every single time we've brought this to a staff member, they have been over the moon about having this as a tool to kind of demystify the hospital market and help them really understand how an individual policy that they're evaluating or that they even might be writing will actually have an impact on all of the different sources of care within their community or their state.
Thank you, Brian. And yeah, not a monolith. That's really the watchword here. I'll turn it over to Caitlin. Brian, you gave us the federal perspective. Caitlin, would love your insights at the state level. How do you think advocates and policymakers can use this tool to better understand the differences between the hospitals, but also to design more targeted, more effective legislation?
Yeah, I think that's a really good question. I think it's very similar to what is happening at the federal level and helping policymakers really understand how systems are similar and how they are different. I think taking sort of a small step back, I one of the things that is happening in states across the country is that, people who experience the healthcare system, the cost of care is the number one healthcare concern that they have, right? Like, my costs are too high. And we know that hospital care is like where we spend the most amount of money in healthcare. And so I think it really, really matters to both advocates and policymakers in the states to really understand where that cost is coming from. And I think that comes from not only prices, but also like, the business relationships that facilities have with one another, the who owns who, how is consolidation happening, and how is that impacting price? And so then how is that impacting people's experience accessing care? And so I see this report very much like teaching a man to fish, right? It's giving policymakers and advocates the tools to find the information they need to either verify or discredit the statements that are being made by industry when policy solutions are being considered at the state level. And so I think while national partners and academic experts, right, are so excited and happy to help state policymakers move through those policy discussions, um, you know, there's not millions of people who understand the depth of this information. And so this report really, I think, can be a starting point for people to start to understand and build that foundational knowledge so that they can sort of go toe to toe with industry and be able to understand if like if the claims that they are making are sort of true or not, and not always having to sort of go back and check in and really be able to engage in those dialogues. And I think from that, then you can really design meaningful policies that are targeted at specific actors or specific problems that you're trying to solve. So rather than starting from a place of we're just going to create this policy that blankets everyone and then have to sort of back into exemptions, you can sort of start to design the policy from the get-go on the problem that you're trying to solve, and like really target in. Sorry, that was a really bad way to end that sentence, but
No,
I think you got what I'm
that's
saying.
helpful. It's kind of putting everyone on a level playing field in terms of knowledge and understanding. I'll stick with you for just a minute. Can you maybe give us examples or tell us about what does this report bring clarity to that might have previously been difficult to understand or difficult to see without having this resource at your fingertips?
Well, certainly the ownership transparency or relationships between different health systems and facilities, right? Like that, I think that component, it's like a very complex web, right? We've got insurance companies owning hospitals, we've got hospitals owning providers, we've got hospitals owning one another, and they're really able to move money around within those large systems in a way that we can't really see unless we're really digging very deeply into some of these data sets, and we don't necessarily know where to find the data set or how to interpret the data. And so I think that this guide does a really good job of saying, like, here's what you need to look at, here's what you're looking for, and here's sort of how to interpret the data. We work in states across the country on this, and we have people coming to us saying, can you build us profiles on, these hospitals, because that's what legislators want to know about. And we don't really have the capacity to do that in every single state. And so sort of putting that information out there to help people sort of hone in on what are the questions I need to ask and where do I find the data to answer that question, I think is really important.
Thank you. We'll get to Q&A in about 10 minutes. You don't have to wait 10 minutes to put your questions in there. Feel free to submit your comments in the Q&A box. We'll switch to Maureen. Maureen, your organization, NASHP, you've really long helped states understand hospital financing and consumer costs. So tell us a little bit about how this resource complements some of the tools that your organization has already made available.
Sure. So I'll start just highlighting that the answers that were previously given, I just echo. So state officials are in positions that others may not be in. They are regulators, they have information that others that are striving to improve the affordability of the system don't come with that knowledge that state officials sort of enter into this conversation with. So NASHP supporting state officials, when we create our tools, we create them for the state official audience. And very specifically, our hospital cost tool was created to answer state questions. We quickly learned how important it was to make sure that state-based advocates, employers, other purchasers, consumers of healthcare are not starting in the same position that state policymakers, state implementers, state regulators are starting from. So some of our tools can be looked at with a lens of, I know this hospital, I know that it's a government hospital, or I know that it's a nonprofit, I know how many beds are in it, I know that it's this. That's wonderful, and that's one piece of policy making. But this tool helps others that are entering into the affordability conversation understand why things like, is this an acute care hospital that is consolidated or independent? Why does it matter if this is a critical access hospital, or people use acronyms like a CAH, and what does that mean and how does that differ? And why does policy have to change? Why, when looking at some of the numbers that, for instance, my organization can provide, why are they so different between two different hospitals that may be in the same state, maybe in the same city? As folks are looking at some of our tools, they will say to us, like, this number has to be wrong because it's so different from this hospital. And then we'll say, I can explain why that number is so different between the hospitals, but it's usually related to what type of hospital it is. It's usually related to the payer mix that's driving those hospitals' revenue sources. And so this tool provides an opportunity to level the playing field so that others can have productive conversations about policy and about price and cost.
Thank you, Maureen. Well, that is a perfect seg to my next question. We've been talking about kind of all the opportunities that will open themselves up once we have that understanding. But maybe look at it from another perspective. If we don't have a clear understanding of these distinctions between different types of hospitals and different type of financing models, what are the risks? What are the consequences for the public when we're not informed the way we should be?
Yeah, I'm happy to start, and I can give a really concrete example. We were getting, so we being NASHP, getting some questions very recently about payer mix. So our hospital cost tool has a lot of different details, and payer mix is one of those details. As things are changing or likely to change with Medicaid, a very important payer for both consumers, policymakers, but also hospitals themselves. There is some assumptions being made that there will be, and there could be, dramatic shifts in Medicaid payment for a lot of different reasons. But so individuals have started coming to our tool and saying, we're going to take a snapshot of all of the hospitals that have a very high Medicaid payer mix. Those must be the hospitals that are at risk of closure. That's a really, really dramatic step. And I'm not saying that some of them aren't. Some of them are at risk of closure with major Medicaid changes. However, across the board, that's not necessarily true. And so we start having conversations with folks like Caitlin and Brian were just highlighting. You have to understand, is a hospital part of a system or is it not part of a system? Because systems can transition funds across their affiliated members to help better finance an entity so they're not at risk at closure. Or you have to better understand the like bed sizes and what that means. You have to understand, is this particular hospital likely to have even supplemental payments beyond just a Medicaid fee-for-service payment? All of these things matter a lot in trying to understand an overall hospital's financial health. And I'll even just say, as much as all of these resources help provide more information, there have to be follow-up questions. There have to be follow-up questions to hospital systems, hospital associations, because they are the real experts in understanding the dynamics of their financing. But we need outside folks to be educated enough to know what questions to ask. So I'll just leave it there and say there's lots of different dynamics that are going to start taking shape, and understanding how some of the categories of ownership categories, size of hospitals, location, payment, all of these things matter. And this tool helps break that down and explain why.
You mentioned closures, so we'll keep pulling on that thread. We got a question in the Q&A from Miriam Strauss, and she wants to know, for advocates and policymakers concerned about hospital closures, what are the biggest warning signs we should be looking at? Is it operating margins, net revenue, the uncompensated care mix, or and then she's also wondering that since some of these reports lag a few years, what advice do you have for advocates that are worried about potential closures due to coverage losses in the coming years?
So I can take the first stab at that, but I welcome my fellow panelists to weigh in because this is a very hard question. And I am in a lot of conversations with these same questions being asked. I'll just share from NASHP's perspective, there is no one metric that can be used to identify this. And I understand the questioner isn't considering just one metric. I think looking across all of those metrics, payer mix, I think operating margin, I think net profit margin, I think all of those are really important. I would also take a look at the trends over time, because to the questioner's point, our data lags. And our data, NASHP's data, comes from Medicare cost reports as well. We have just added 2024 data, but we have just rung in 2026, so we know that it's already old. And the policy changes that are coming in the future that are going to have dramatic effects on this. So I would say, though, when you look at trends over time, you can see if there are major shifts in operating margin, in net profit margin. You can take a look and see, are there changes in staffing that look strange? Are there changes in, we look at a measure that's I'm blanking on right now, but it's like per, I'm going to get it wrong, but I'll follow up with it. But taking a look at the break even measure that's in our tool to understand how much does a hospital have to charge, looking at the Medicare rate to meet its expenses. And if that is creeping higher and higher, then a hospital may have an expense problem. And so a revenue problem on top of that could be something that puts a hospital into financial challenges. So I would just say multiple different metrics to look at, and also look at the trend over time. If you see something like a profit margin or break even that's pretty steady, then that's actually a more positive sign than one that's a little more erratic.
Thank you. I've got one for I think this would be good for Brian Connell. Had a question about why are hospitals concerned about price transparency?
Yeah, I will say I don't work for a hospital, and we don't have anyone who works for a hospital on the as a panelist. So let them speak for exactly, their concerns. That said, and I will say that they're not quiet about that. So you can check out their websites, and I think you'll get a sense of their concerns. I do think, we see this across industry stakeholders in healthcare that folks have been very comfortable for a very long time with the model of opaque pricing. I think a lot of people understand it, understand how it works. They view, essentially all their models and processes are designed around this keeping the prices secret or opaque. And I think that we've realized that doesn't work for consumers, doesn't work for the payers who are actually footing the whole bill, and it doesn't work for patients who are footing a really enormous and growing out-of-pocket cost. Doesn't help consumers who are paying the premiums either. So I think we support transparency at Blood Cancer United. I think a lot of folks do because I think there's benefit to understanding what the incentives are, where money's going, so that we can really fine tune how we pay for healthcare in a way that's actually going to be a real benefit, where we get higher quality care and we also get care that's more affordable for people.
Thank you, Brian. Got a question. Probably this would be a good one for Caitlin. George Timmons. George wants to know: are there metrics or indicators for comparing wealth between hospitals that you almost regularly lean on or recommend for creating distinctions between hospitals related to their financial health?
Well, I think what Maureen said earlier about like there's not like a one size fits all sort of look at this indicator and if a hospital is doing well is very, very true, right? It depends heavily on what your infrastructure looks like, what facilities you have, if you're nonprofit, if you're for profit, if you're independent, sort of how you're categorized. So unfortunately, the answer is not easy. And I think you're going to have to look at a lot of different metrics. And I really like the suggestion to look at trends over time, because you never know sort of when a policy change or an adverse event may impact a hospital sort of for a year, but then the rest of the years look really good, and so or vice versa. And so I think that that's really important. I would say the one sort of metric that we look at, in addition to all of the things that Maureen mentioned around operating revenue and break-even point, is also days cash on hand. And I wouldn't necessarily say that if you're looking at days cash on hand, that if it's really low, that's an indicator that a hospital is going to close. But if they're sitting on a mountain of days cash on hand, then it's probably a pretty good indicator that they're doing well, or at least have some protection to do well. But again, I can't emphasize enough that you can't just look at that. You have to look at sort of the whole picture. And not to sound like a marketing ad, but that is, I think, part of the reason why the report is helpful, is because it's sort of, you can start to piece some of that together.
Yeah. Got a question for Kenna or anyone else who wants to take a stab at it. Someone wants to know: are we going to keep this resource up to date? Because the rules are always changing and there's always new data coming out.
Yeah, that's a great point. I think we would love to keep it up to date to the extent possible with new data, with changes to rules and regulations, or just with building out new sections. I mentioned in the presentation, we don't include state level Medicaid information. Maybe that could be an area to expand in the future. But I don't know if Brian or anyone else wants to add on.
I've got another question, probably for you, Kenna. This is my own question, by the way. Can you spend a moment just talking about some of the resources and tools you linked to and referenced at one of the last pages of the report? I'm glad I got to it, because I was looking at a lot of them, and some of them are pretty amazing. Could you just talk a little bit about a few of those?
Yeah, definitely. So similar to how the guide is structured with those 6 kind of different sections and categories of hospitals, we tried to break that section down into different places where you could learn more about those 6 kind of different categories of hospitals. So for example, if you wanted to learn more about who owns a hospital, I think Sage Transparency and the Private Equity Hospital Tracker are really great places to start. So these are folks who have gone out and identified the ownership status of hospitals, as well as in the case of the Private Equity Tracker, ultimately if they're backed by private investors or not. But we also have tons of other resources there for folks who want to dive into the kind of financial well-being or status of individual hospitals. I think the hospital cost tool from NASHP is front and center on our list, and for an important reason. And similarly, Sage Transparency, the Lone Hospital Index, and other sources that we list there can help folks kind of look into that year over year trends in data. But just a reminder that depending on the source you're using there, you'll get different outputs, you'll get different years of data. And so you can really tailor those tools to what you're hoping to find about a hospital in a certain situation or year.
Great, thank you. Next one, probably start with Caitlin, but anyone's welcome to take a stab at it. What do communities tend to understand today about their local hospitals? So what do they understand, and what information is usually missing from that picture?
Yeah, that's a great question. I think people don't understand a lot, I think, about how the hospital is integrated into the healthcare system, right? I think they see them as providers of care, right? They are places where people go when they get sick or they need help, but sort of beyond that, there isn't a lot of understanding around the infrastructure. And so people don't really blame them for being responsible for any of the things that we've been talking about related to price or consolidation or sort of having a role beyond being the provider of care. And so what we see when we talk to people, because US of Care does a lot of listening work at the state level and at the national work. And so when we ask these questions, what we learn from people is that they, sometimes are sort of dissatisfied with for-profit systems, but they view nonprofit systems very favorably and don't really see them as financially motivated. We hear people say that the hospitals don't really have a role or are responsible for controlling or setting prices, and they think they sort of just like take what they can get from the insurance company. People think that higher costs equal higher quality, and that if you reduce the cost, that your quality will inherently suffer. And then I think the one place you see that sort of start to fracture a little bit is when you talk about CEO pay and sort of like people are dissatisfied that CEOs make large salaries, right? And so that's like sort of what people know. And I think part of what is missing from that conversation is obviously all of the stuff that we're talking about, but that like in some cases prices are already unjustified, and like the consolidation, the ownership, relationships is driving up that price. And hospitals at the end of the day are a business, right? Like even the nonprofit ones have to sometimes they're not sort of operating the way that most people would expect a nonprofit to be operating with respect to charitable giving and taking care of communities. But I think at the end of the day, they're all sort of trying to make enough revenue, have enough profit, and make business decisions that maximize those things, and that the patient is not always at the center of that decision making. And so I think there's sort of a education that needs to happen around how hospitals are operating in order to be, sort of as businesses in the healthcare system, in addition to providers.
Great, thank you. Got another question. This may be a fit for you, for Caitlin as well. Are you monitoring the rural health transformation grants, and are states planning to use them to invest in rural hospitals?
We are. I will say I'm not the best person for my team to speak to this. I think that generally rural health transformation fund grants are going to be used to invest in rural hospitals. I think every state is sort of going to approach that a little bit differently, whether or not they're sort of taking the trends that we see is like investing in workforce, right? So not necessarily sending money directly to a hospital as sort of like you can do whatever you want with this, but really targeted at sort of workforce investments. And then I think we do see a chunk of hospitals investing in like value-based care strategies. So figuring out how are we going to pay differently for care in a more sustainable way. And at US of Care, we've been really encouraging people to sort of like lean into that lane of work and thinking about, are there global budgets or other payment models that can sort of provide that sustainability, especially in rural areas where the fee for service system may not be working. And yeah, I don't know. I'm sure, Maureen, you all are also monitoring this.
We are, and I will admit that I'm not the lead in that area either, but I will say we're watching the same exact things that you are, Caitlin. The other thing that I would add to that is there are some inappropriately pretty strict guidelines from the federal government on what states can do with those rural health transformation grants. They really are intended to be sustainable investments, and in any situation, funneling funds directly into in a short-term way into something that can't be sustained over time. These grants are limited. Isn't going to work for a lot of state officials. So that's why we're seeing a lot in workforce. That's why we're seeing states try to invest, for instance, in like IT and infrastructure for hospitals. Those are one-time payments that particularly smaller and rural hospitals struggle to be able to come up with the cash to invest in to keep them connected, and to be able to help serve patients appropriately. But if there is a particular financial problem with a rural hospital, again, adding just funds for like a year or even 4 years and then having that go away does not necessarily fix the underlying issue. And so states are really trying to understand what the underlying issues are to build a sustainable bridge going forward. And I think we'll see a lot of innovative approaches. But I know there are actual conversations happening right now between states and CMS to ensure that both parties feel like these investments are going to have that sustainable outcome they want.
Um, I'll make one last call for questions, but in the meantime, I'm just curious. Any ideas or any I'd love to hear any insights about how the three of you might plan on using this report in the coming years. Anything that's really standing out at you that you're going to be bookmarking in this report as you continue your work.
I'm happy to jump in and say, as NASHP gets a lot of questions from folks very interested in sustaining access to hospitals, but making sure that we can do so affordably. I am very excited to be able to share this information and say, here's a link to the hospital cost tool. Here's a link to policies that states have spent time crafting. But here's the backdrop, and here's the information that you need in order to do what we just talked about, make sense of some of this cost data, and that the cost data and overall hospital financial health can actually be two separate things. So then also understanding like we're getting pushback in the legislature to carve out all nonprofit hospitals. Is that the right way to go? And again, NASHP is never going to be in a place to say yes or no to that question, but to have information on what it means to be a nonprofit hospital. Is that what you want to carve out versus maybe carving out a critical access hospital or carving out safety net or government funded hospitals? Like being able to target policies appropriately based off of factual data is so important. And so I think this information will really be helpful in that.
Yeah, I'd just add, I think that the better question is probably like, when will we not use this? Because I think we're going to be using it in so many different conversations. I mean, I mentioned just at the top the whole host of hospital related policies. Some are payment related, some are not payment related. But in all of them, it really does help for the lawmaker, policymaker to understand, when someone comes in my office and says this specific rural designation, what does that mean? Like, I know it says rural, but what does it mean? Or urban? And I think that has applicability across so many different conversations where lawmakers really do want to get it right. And they do want to understand the information that's coming to them from their communities. But right now they don't feel like they have the tools to understand that. Like when, 8 hospitals from my district are sending me information, it all sounds vaguely similar, but they're using slightly different wording. Like, what does that actually mean? I think this helps them kind of decode those arguments in a way that helps them understand what is the impact of any given policy on the people I represent. And I think it's going to be so invaluable that I think we're going to be using it at Blood Cancer United pretty constantly.
I think that's very true in the States as well. And I think this is so helpful because there are so many data sets. Well, not so many, but there are a handful of data sets out there where you can get real weedy, real wonky, really fast. And this sort of helps pull it up a level to make sure that we can interpret it. And I'm just thinking about, all of the state advocates that sort of come to us with questions and text us and say, is this true? And now we have something that we can say, well, like can you start digging sort of first or along with us, because you can't respond to everybody all at once. And so I think it's really helpful in that respect.
Very, very empowering. Well, thank you all so much. Thank you, Brian, Caitlin, Maureen, Kenna, and Christine. Very grateful for the time you've spent with us, and thank you to all 70 of you who joined in. We will have a survey that should pop up at the end of this session, and just want to say thank you for everyone who attended, and hope you're able to make great use of this resource.